Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Clinical Pathologic Predictors of Sentinel Lymph Node Metastasis in Thin Melanoma by Dale Hahn et al. My name is Dr. James Goitis, and I am a professor of surgery in the Division of Surgical Oncology at Rutgers Cancer Institute of New Jersey in New Brunswick, New Jersey, in the USA. I am the director of the Melanoma and Soft Tissue Oncology program at our institution. Melanoma has become a significant health problem over the past few decades, with over 76,000 cases expected in the United States in 2013. As the incidence of melanoma increased, new techniques were developed to stage and treat these patients. Sentinel lymph node biopsy, also known as selective lymphadenectomy, was first described by Morton et al. In 1992 as a way to accurately stage the regional nodal basin in patients with cutaneous melanomas and clinically negative lymph nodes. Though some controversy remains as to the benefit of performing a sentinel node biopsy in patients with cutaneous melanoma, the utility of this technique as a staging modality is generally accepted. Multiple studies have shown that the status of the sentinel lymph node is one of the most important prognostic factors in patients with cutaneous melanoma, and sentinel node status has been incorporated into the most recent updates to the American Joint Committee on Cancer, AJCC, melanoma staging system. It is also generally accepted that in patients with primary melanomas between 1 millimeter and 4 millimeters in Breslow thickness, the risk of occult nodal metastasis is great enough to warrant a sentinel node biopsy. However, controversy remains as to when to perform sentinel lymph node biopsy in patients with melanomas less than 1 millimeter in thickness, even though the prognostic significance of a positive sentinel node in these patients has been established, with a worst 5-year melanoma-specific survival in patients with occult nodal disease. In an attempt to identify patients with melanomas less than 1 millimeter in thickness that may benefit from a sentinel node biopsy, recent studies have focused on other characteristics of the patient and the primary melanoma as possible significant prognostic variables. These include patient age, gender, the presence of ulceration, mitotic index, Clark's level, the presence of regression or lymphovascular invasion, and location on the body of the primary. The authors of these studies have drawn different conclusions, and a definitive set of criteria to guide clinicians has remained elusive. The study reported in the article by Hahn and Ziegler et al. That accompanies this podcast attempts to better define the criteria that clinicians can use to select patients with melanomas less than 1 millimeter in thickness who have a significant risk of harboring occult nodal metastatic disease. The authors are members of the Sentinel Lymph Node Working Group, an organization that consists of 30-member institutions. Patient data are submitted and updated by each member institution through a password-protected website into a standardized database maintained at the Vanderbilt University in Nashville, Tennessee. The authors used this database to examine patient records from 1994 to 2012 and identified 1,250 patients who had melanomas less than 1 millimeter in thickness who had undergone sentinel lymph node biopsy. Their goal was to determine which clinical pathologic characteristics of the patients and their primary tumors would best predict the presence of occult disease in their sentinel lymph nodes. They included a range of covariates in their analysis, including age, gender, histologic type of melanoma, location of the primary, Breslow thickness, Clark level, the presence or absence of ulceration, mitotic rate, the presence or absence of regression, vertical versus radial growth phase, the presence or absence of lymphovascular invasion, and the degree of tumor infiltration by lymphocytes. Of the 1,250 patients in their data set, the authors found that 65, or 5.2%, had positive sentinel lymph nodes. The only firm recommendation that the authors could draw from their analysis was that sentinel node biopsy should be performed for melanomas greater than or equal to 0.75 millimeters in thickness, but not for melanomas less than 0.75 millimeters in thickness. The rationale for this recommendation was that 6.3% of patients with melanomas greater than or equal to 0.75 millimeters in thickness had positive sentinel nodes in their study, while patients with melanomas below 0.75 millimeters in thickness had less than a 5% chance of having a positive sentinel node. This held true even when other factors such as presence of ulceration or a Clark level of 4 were taken into account. These factors increased the likelihood of finding a positive sentinel node only when the primary was greater than or equal to 0.75 millimeters in thickness. 14.7% of patients with ulcerated primary tumors greater than or equal to 0.75 millimeters in thickness had positive sentinel nodes compared to only 6% of patients with non-ulcerated tumors greater than or equal to 0.75 millimeters in thickness. This is the main takeaway for clinicians. Sentinel node biopsy can be avoided in patients with melanomas less than 0.75 millimeters in thickness and is recommended when the primary tumor is greater than or equal to 0.75 millimeters in thickness, especially if the primary is also ulcerated. Other variables that have been found to hold prognostic significance in past studies, such as patient age, gender, presence of tumor-infiltrating lymphocytes, and regression of the primary, were not found to predict the presence of occult nodal disease in the present study. Because this was a retrospective analysis using data from many different centers that use a variety of different techniques and methods for determining the characteristics of primary melanomas, the authors admit that it may be difficult to compare factors such as the presence or absence of regression, where subjective analysis is often used. Similarly, factors used by different clinicians when choosing to perform or not perform a sentinel lymph node biopsy in the very young or the very old can influence the likelihood of finding occult nodal disease. Because of these factors, Hahn and Ziegler et al. Wisely refrained from drawing firm conclusions concerning these variables. Surprisingly, the authors did find that Clark level had a significant impact on the likelihood of finding a positive sentinel lymph node in patients with melanomas greater than or equal to 0.75 millimeters. 8.2% of these patients had positive nodal disease if their tumors were Clark level 4, but only 3.7% did if their tumors were Clark level 3 or less. Equally surprising was their finding that mitotic rate, or mitoses per millimeter squared, was not a significant prognostic variable even in patients with tumors greater than or equal to 0.75 millimeters in thickness. These findings contradict the findings from other recent studies, and the most recent update of the AJCC Staging Manual, 7th edition, includes mitotic rate in the T classification, but for the first time in 40 years does not include Clark's level. It will be interesting to see if future studies confirm Clark's level as a significant prognostic variable, and whether the next update of the AJCC Staging Manual will once again include this variable in the T classification. Adding to the confusion as to the importance of mitotic rate in determining the likelihood of occult disease in patients with melanoma is the introduction of immunohistochemical staining for phosphohistone H3 as a surrogate marker for mitotic rate. The current AJCC staging system upstages a primary tumor's T classification if one or more mitotic figure per square millimeter are found on routine examination. Hahn and Ziegler et al. Used the same system in the current study, where they found that mitotic rate in thin primary tumors did not influence the likelihood of finding occult nodal disease. It will be interesting to see if the detection of phosphohistone H3 will be found to be a better predictive marker than mitotic rate, and whether this technique will also be incorporated in future staging systems. These authors have also confirmed the status of the sentinel node as a significant and important prognostic variable, even in patients with melanomas less than 1 millimeter in thickness. As the morbidity associated with sentinel node biopsy remains very low in experienced hands, and the finding of a negative sentinel node can save patients the anxiety and expense of intense clinical follow-up, the recommendation by these authors of performing a sentinel node biopsy in patients with melanomas greater than or equal to 0.75 millimeters in thickness appears reasonable and appropriate. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.